Specific fractures and joint injuries in children. Spatial features of fractures and dislocation in children. 1. Fractures are common. 2. Stronger and more active periosteum. 3. More rapid fracture healing. 4. Special problem of diagnosis. 5. Spontaneous correction of certain residual deformities. 6. Differences in complications. 7. Different emphasis on method of treatment. 8. Torn ligament and dislocation are less common. 9. Less tolerance of major blood loss. 1. Fractures are common. Slender bones and carefree capers lead to higher incidence. Some injuries are not serious, but others, like intra-articular fracture and epiphyseal plate fracture, are very serious indeed. When the children is not yet walking, but there are some evidence of fractures or joint injury, you must consider a child abuse case. 2. Stronger and more active periosteum. Stronger periosteum means more periosteal hinge that can be used during close reduction. 3. More rapid fracture healing. The remarkably high osteogenic activity in periosteum and osteum causing the fracture bone healing faster. The rate of healing in bone varies much more with age, particularly during childhood, than it does in any other tissue in the body. 4. Special problems of diagnosis. The radiographic appearance of a child with the given epiphysis may confuse the inexperienced and falsely claims it is a fracture line. Solution: compare to the healthy or unaffected side of extremity. 5. Spontaneous correction of certain residual deformities. In adults, the deformity of a malunited fracture is permanent, but in children, certain residual deformities tend to correct spontaneously either by extensive remodeling or epiphyseal plate growth, and sometimes by a combination of both. Just how much spontaneous correction of the healed fracture deformity can be anticipated depends on the age of the child, hence the number of years of skeletal growth remaining, and the type of deformity. Differences in complications. Growth disturbance after epiphyseal plate injuries occur only in children. Osteomyelitis secondary to either an open fracture or open reduction of a closed fracture tends to be more extensive in a child, and the infection may even destroy an epiphyseal plate with resultant growth disturbance. Foxman's ischemia or compartment syndrome of nerves and muscle is much more common in children, as are post-traumatic myelitis. 7. Different emphasis on methods of treatment. Virtually all fractures of the long bones in young children can and should be treated by means of close reduction, either by manipulation or by continuous traction. Certain fractures in children do necessitate open reduction and internal skeletal fixation. 8. Torn ligaments and dislocations less common. Children's ligaments are strong and resilient. They are stronger than the associated epiphyseal plates. Sudden powerful traction on a ligament at the time of injury results in a separation of the epiphyseal plate rather than a tear in the ligament. Solution: compare to the healthy or unaffected side of the extremity. 9. Less tolerance of major blood loss. A formula for estimating the approximate blood volume in a child is 75 ml per kilogram of body weight. Consequently, external hemorrhage of 500 ml in such a child represents 33% of the total blood volume, whereas a similar hemorrhage in an average adult would represent only 10% of the total blood volume of 5,000 ml. Solution: always aware with the blood loss and the body weight of the children. Assess and treat as soon as possible. Specific fractures in children. Salter-Harris classification. Type 1. Complete separation of the entire epiphysis without any fracture through the bone. Type 2, the line of fracture separation extends along the epiphyseal plate to a variable distance, then out through a portion of the metaphysis. Type 3, intra-articular, extend from the joint surface to the deep zone of the epiphyseal plate, then along the plate to its periphery. Figure 16.12, Type 1 epiphyseal plate injury, separation of the entire epiphysis. Figure 16.13, Type 2 epiphyseal plate injury, fracture separation of the epiphysis. Figure 15.14, Type 3 epiphyseal plate injury, fracture of the part of the epiphysis. Salter-Harris classification. Type 4, intra-articular, extend from the joint surface through the epiphysis across the entire thickness of the epiphyseal plate and through a portion of the metaphysis. Type 5, result from a severe crushing force being applied through the epiphysis to one area of the epiphyseal plate. It is most likely to occur in the region of the knee and ankle. Figure 15.15, Type 4 epiphyseal plate injury, left, fracture of the epiphysis and also the epiphyseal plate. Right, unless the fracture is perfectly reduced, bony union will cause premature closure of the plate. Figure 16.16, Type 5 epiphyseal plate injury, left, crushing of one side of the epiphyseal plate. Right, premature closure of the plate on one side with a resultant angulatory deformity. Clinical manifestation suspected in children with injury. Signs: local swelling and local tenderness, fracture around the end of the long bone, traumatic dislocation, ligament tear injuries including sprain. Radiological examination. Precision diagnosis with at least 2 radiological projections at correct angles. If in doubt, the appearance of radiolucent indicates a fracture or epiphyseal plate is examined on the contralateral side with the same projection. Differential diagnosis: apophysis, septic arthritis, arthritis tuberculosis. Complication and prognosis. Prognoses are based on type of injury, the child's age at injury. The younger the growth disorder are the more serious. Blood supply to the epiphysis. Impaired blood supply to the epiphysis. The prognosis is getting worse. Reduction method: open or closed injuries. Open fractures increase the risk of infection damaging the epiphyseal plate, premature closure of the epiphyseal plate. Complications: growth arrest, overgrowth, deformity, angulation. Distal third of radius and ulna incomplete fractures. In young children, the most frequent fracture in this region is the buccal type, which requires protection alone for 3 weeks. Green stick fractures of the distal metaphyseal region on the radius and ulna require close reduction by manipulation if the angulation is significant. The angulation is gradually corrected to the point where the remaining intact part of the cortex is heard and felt to crack through, but not become displaced. Figure 16.27. Buccal fracture of the distal metaphysis of the radius and a crack fracture of the ulna in a child. The angulation deformity with buckling or clumping on the thin dorsal cortex is apparent in the lateral projection. This is sometimes referred to as a torus fracture because of the ridge on the cortex. From the Latin, torus means a ridge or protuberance as seen at the base of a column of a building. Supracondylar fracture of the humerus. Displaced supracondylar fractures of the humerus are the most common and certainly the most serious, associated with a high incidence of malunion with residual deformity and with the serious risk of Volkmann ischemia or compartment syndromes of nerves and muscles of the forearm. Supracondylar fracture of the humerus. Clinically, there is obvious deformity in the elbow region that soon becomes grossly swollen and tense as a result of extensive internal hemorrhage. Radiographic examination provides striking evidence of displacement of the fragments, but little evidence of the severe soft tissue damage. The distal fragments lies posteriorly and there is intact posterior hinge or periosteum. Figure 16.47 displays supracondylar fracture of the left humerus in a 7-year-old boy. Left, in the anterior-posterior projection, the distal fragment of the humerus is displaced medially and proximally. Right, in the lateral projection, the distal fragment is displaced posteriorly and proximally. The jagged end of the proximal fragment is lying in the soft tissues of the antecubital fossa. Classification of supracondylar humerus fracture. Garland's classification. Type 1, undisplaced fracture. Type 2, angulated fracture with intact postural contact. 2A is milder, while 2B is more severe. Type 3, completely displaced fracture. Treatment of supracondylar humerus fracture. For type 1, undisplaced supracondylar fractures require only immobilization of the arm with the elbow flex for 3 weeks. For type 2A, close reduction under general anesthesia followed by immobilization in the elbow joint in 90-degree position for 3 weeks. Type 2B and 3, close reduction CRPP, close reduction percutaneous pinning with 2 Kirchner's wire followed by immobilization with the elbow joint in 90-degree position for 3 weeks. Complication of supracondylar humerus fracture. Vascular injury, Volkmann ischemia, nerve injury, anterior interosseous nerve, medial, radial, ulnar neopraxia, malunion, elbow stiffness and myositis ossificans. Fractures of the femoral shaft. Displaced fractures of the femoral shaft are common in childhood and merit special consideration. The diagnosis is obvious from clinical examination alone because of the typical deformity. It is essential to apply a temporary splint, such as a Thomas splint, before radiographic examination is undertaken to spare the child unnecessary pain and to prevent further injury to the femoral artery. Treatments of femoral shaft fracture. Age 0 until 5 years, skin traction for days, hip spica cast with hip and knee slightly flexed. For children over 0 and 2 years, Bryant traction or overhead traction. For children aged 2 until 5 years, Thomas splint with inclined frame. Age 5 until 10 years, skin traction for several days, close reduction and hip spica cast, inserting a flexible intramedullary nail. Age more than 10 years, skin traction for a period of time, followed by rigid and lock EM nail. Thank you.